Pancreatic islet cell tumors. Insulinoma. This is a tumor of pancreatic beta cells that causes overproduction of insulin, leading to hypoglycemia. The classic finding is Whipple's triad. This includes low blood glucose, symptoms of hypoglycemia, such as lethargy, fainting, or double vision, and resolution of these symptoms once plasma glucose levels normalize. In symptomatic patients, blood glucose is low and C-peptide levels are elevated, which helps distinguish it from exogenous insulin use. About 10% of cases are associated with MEN type 1 syndrome. Treatment is surgical resection. Glucagonoma. This is a tumor of pancreatic alpha cells that produces excessive glucagon. It presents with the 6 Ds: dermatitis, specifically necrolytic migratory erythema, diabetes with hyperglycemia, deep vein thrombosis, declining weight, depression, and diarrhea. Treatment includes octreotide and surgical resection. Somatostatinoma. This is a tumor of pancreatic delta cells with excess somatostatin production. It decreases secretion of many hormones including secretin, cholecystokinin, glucagon, insulin, gastrin, and gastric inhibitory peptide. Patients may present with diabetes or glucose intolerance, steatorrhea, gallstones, and achlorhydria. Treatment is surgical resection with somatostatin analogs such as octreotide for symptom control. Carcinoid tumors. These tumors arise from neuroendocrine cells, most commonly in the intestine or the lung. Neuroendocrine cells secrete serotonin. Normally, serotonin is metabolized by the liver and broken down by monoamine oxidase in the lung. However, if serotonin reaches the systemic circulation, usually due to liver metastasis, the carcinoid tumor can present with carcinoid syndrome. This syndrome is characterized by episodic flushing, diarrhea, wheezing, and right-sided valvular heart disease, such as tricuspid regurgitation and pulmonic stenosis. Urinary excretion of 5-hydroxyindoleacetic acid is increased. Excess serotonin production can deplete tryptophan stores, leading to niacin deficiency and pellagra. On histology, carcinoid tumors show rosettes, and they stain positive for chromogranin A and synaptophysin. Diagnosis is made by elevated 24-hour urinary 5-hydroxyindoleacetic acid. Octreotide scintigraphy is used for tumor localization and staging. Treatment includes surgical resection, a somatostatin analog such as octreotide, or a tryptophan hydroxylase inhibitor such as telotristat for symptom control. A useful way to remember carcinoid tumors is the rule of thirds. 1/3 metastasize, 1/3 present with a second malignancy, and 1/3 are multiple. Zollinger-Ellison syndrome. This syndrome is caused by gastrin-secreting tumors called gastrinomas, which are usually located in the duodenum or pancreas. It presents with single or multiple recurrent ulcers in the duodenum or jejunum that are often resistant to proton pump inhibitors. The excess acid also inactivates pancreatic enzymes in the small bowel, causing malabsorption. Symptoms include abdominal pain, heartburn, diarrhea or steatorrhea, and weight loss. A positive secretin stimulation test is diagnostic, where gastrin levels rise after secretin administration. Normally, secretin inhibits gastrin release. These tumors stain positive for chromogranin A and may be associated with MEN type 1.